Welcome, everyone, and thank you to those joining us live and to those listening afterwards. I'd also like to warmly welcome our guest speakers today, whom I'll introduce you to shortly. Today's webinar is entitled Empowering Pharmacists in Palliative Care, Support and Impact. This is the second of 3 webinars that FIP is hosting throughout October as part of the series, The Role of Pharmacists in the Care of Older Persons. Palliative care is essential to improving the quality of life of older persons with life-limiting illnesses, addressing complex physical, emotional, and social needs. Pharmacists, as accessible healthcare professionals, play a key role in optimizing medication use, managing symptoms, and supporting patients and families during this stage of care. This webinar, in recognition of World Hospice and Palliative Care Day 2025, which will be celebrated this Saturday, will explore how pharmacists can contribute to palliative care services, highlight best practices in cancer-related palliative care, and discuss global perspectives and essential communication skills to empower pharmacists in delivering compassionate, people-centered support. My name is Dr. Betty Chaar. I am an associate professor at the School of Pharmacy at Sydney University, Australia. I am the co-chair of the Ethics Advisory Group and a fellow of FIP. My research centers on pharmacy ethics, moral reasoning, and the role of pharmacists in patient care. And one of the most important roles is the contribution we make as pharmacists to pain management and alleviation of suffering. As you can see on this slide, we have some announcements to make. Please note, this event will be recorded, live streamed on FIP YouTube, and the recording will be available at events.fip.org. To all those listening, please feel free to send your questions through to the Q&A box, not the chat box. It's provided, and I will do my best to manage all the questions so that at the end, we will be able to address those questions, or at least some of them. You are welcome to provide feedback to webinars@fip.org. And I'd like to take this opportunity to promote the benefits of membership with FIP, including events and webinars. FIP is the global body representing 4 million pharmacists and pharmaceutical scientists around the world. If you are a pharmacist or pharmaceutical scientist and you would like to become a member, please register on the FIP's website at fip.org. Now, for translation, please follow the instructions on this slide. Step 1, turn on the captions, as you can see here. Enable the translation toggle in step 2. And step 3, choose your preferred language under My Caption Language. And now you can just follow along with us with live translation in the captions. FIP would like to thank International Society of Oncology Pharmacy Practitioners, ISOP, for their collaboration in developing this webinar today. And for this event, we are joined by a panel of fabulous speakers. And I want to sincerely thank each of them for taking the time to prepare their presentations and share their wisdom. We will be joined by Dr. Elizabeth Matfeld, Dr. Aline Haj, Dr. Gisem Julpina, and Mr. Darren Walsh. Today's program is, as you can see on the screen, our first introductions and welcoming. Then we have a talk given to us by Dr. Elizabeth Matfield on global perspectives on palliative care, what the priorities and challenges are. The second talk will be given by Dr. Aline Haj, who will talk to us about optimizing palliative care for older persons, the pharmacist's role and clinical impact. The third talk will be about building trust and supporting patients' communication skills in palliative care, delivered by Dr. Gisam Julpinar. And last but not least, Mr. Darren Walsh will talk to us about pharmacist interventions in cancer-related palliative care. We will then have an opportunity for questions and answers, and we'll wrap up and conclude at the end of that program. There are a number of learning objectives for this webinar. By the end of today's sessions, attendees will be able to understand global challenges and priorities in providing palliative care for older persons. We'll be able to describe the role of pharmacists in optimizing care for older persons receiving palliative care. We'll be able to identify strategies to manage symptoms and support patients and families during end-of-life care, to explore best practices in cancer-related palliative care and the pharmacist's contribution, and to use communication skills, including empathy and active listening, to support older persons and their families in palliative care. So, moving on to our first speaker, Dr. Elizabeth Matfield. Elizabeth has worked more than 30 years in public health efforts, including, but not limited to, tobacco prevention, substance use prevention and treatment, mental health services, HIV services, and efforts to address cancer care. She worked for over 10 years with the United Nations and led the global program to increase access to controlled medicines around the world. Currently, she is working with the Worldwide Hospice and Palliative Care Alliance, overseeing projects in both Bangladesh and Kenya. Welcome, Elizabeth. Thank you for your talk. Over to you.
Thank you very much, Betty. I would like to start my presentation speaking about as a general overview, because I think that looking at it from a systems perspective is important. So just to give people some facts to start with, I thank you, Betty, for giving a very general sense of what palliative care is. But I wanted to share that in the Journal of Pain and Symptom Management in July of this year, we published some results that gave a positive and a negative perspective on what's happening with palliative care around the world. The positive is that since 2017, we have seen an increase, about a little over 30% increase in the number of teams that are delivering palliative care services. So that's a positive. The negative on side of the data is that we're still only serving about 14% of the needs for palliative care around the world. So clearly there are some challenges. And in those numbers, we also know that most of the services that are accounted for in that increase are considered specialized services. But we know that there's a need to integrate into the primary care services, because that 14% is coming from both perspectives, the specialized services as well as the primary care. So I will put the reference for that article in the chat as soon as I'm done sharing. I'm sorry it's not on the slide. So I just want to give a small general overview. What is palliative care? Generally speaking, we're looking at relieving symptoms and complications of serious illness. It often is easily explained as reducing suffering and improving quality of life. For most people, they think this is end of life care. And so it's one of the things that we talk around the world about the fact that it may not be end of life care. It's really looking at a team approach, a collaborative and coordinated approach with an interdisciplinary team that includes pharmacists, doctors, nurses, social workers, physical therapists, occupational therapists, spiritual leaders. It can be community healthcare workers, home care workers, anyone who can support the needs of that particular patient, their family, and their carers. And some of the work that I do, for example, in Bangladesh, it's really asking a community volunteer to go in and help with hygiene or help, getting a haircut, who, just can relieve some of that stress and help them feel like their quality of life has improved. It's very much a holistic approach. So we're looking at, how do we ensure that suffering is reduced and we improve the quality of life physically, emotionally, psychologically, and spiritually for the patients that we serve. It's patient-centered, as Betty clearly said, but it's also looking at the needs of the family and the carers. Because as I often say, it's not, it's not looking at acute care, it's looking at the journey that a person takes when they are diagnosed with a serious illness. So when do we get involved with a palliative care model or palliative care approach? Ultimately, it would be nice if we had the opportunity to think about palliative care as soon as a diagnosis is made. And what I mean by that is not, again, taking away the end of life thinking, but thinking about it from the standpoint of that interdisciplinary team. If a person is diagnosed with cancer or any other long-term illness, we know through that journey that they will experience, moments where they are needing acute care. They will also be experiencing times where they can be at home and get care through perhaps a community care worker. And so it's very important for thinking about that interdisciplinary team from the very start. And I think that's where I'd like to make sure that we think about the role that pharmacists can play in the when, because a pharmacist is looking at the larger perspective of managing medications. And that is a critical piece of managing what that journey is going to look like and reducing suffering can also include managing the medications so that the person is the most comfortable that we can make them. The example that I will share in this particular case is I have a colleague at the Worldwide Hospice and Palliative Care Alliance who is a person living with many physical needs, and she receives palliative care for many years now. And her coordinator for her interdisciplinary team is her pharmacist and is the person who manages her pain management. And so that person has the clearest vision of where she's at on a daily basis. And that is her palliative care leader. And they work and coordinate with everyone else. So in the UK, she is very much benefiting from the use of this kind of a model. We also know that the when has to do with the continuity of the disease process and the complexities that may emerge as the disease progresses. And so the pharmacist role is obviously very important to relieve pain and suffering, but it's also to look at contraindications between medications, all of those pieces. Where do we do palliative care? It really depends on the needs of the patient. Clearly, if a person is diagnosed in an acute phase of the illness, they will be inpatient. They will be in a hospital setting, and they will be receiving the care that they need. They then can progress to outpatient. They can be in their home and in their community, whatever is best for their particular needs and to reduce their suffering. That being said, the pharmacist would play a key role in communicating with that interdisciplinary team if that patient is in the hospital and transitions to going home. There needs to be a significant amount of communication. And then how do we do this? This is where I want to spend quite a bit of my time talking, and that is we need to build some systems. And so I want to share with you a model that the World Health Association has created. There we go. To demonstrate how we would move forward with putting this is a conceptual model of palliative care within your country, within your local area, within your care region, and it's a house. I know that this looks very simplified, but if you think about what's underlying the model, the complexities will be apparent as we go through it. Underneath the grass, you can see the grass that's under the house. There are two green boxes. One talks about empowering people and communities. Palliative care is something that is often misunderstood by even the patient, their carers, their family, but also the community. Most people think of it as end of life, and as I said, it really does not need to be end of life. We're looking at building on an advocacy effort so the community and everyone is aware of what palliative care is, and that's what we do around the world. Health policies are next. Looking at analyzing health policies and having robust health policies that allow for that integrated approach or that promote that integrated approach. And then we get to the actual house. And you'll notice that the research piece is the foundation of the house, that yellow box. And here is where I think that pharmacists have a very important role to play in terms of collecting data and sharing data, being clear about what medications work best, and really striving to have those medications available within your care for patients. If you look at the house, the two walls that make up the house, the one side is the use of essential medicines. And as Betty alluded to, I did spend 10 years working with countries around the world to figure out how do we manage pain? How do we create the opportunities for people to have access to pain medication, but not find themselves falling into addiction and the services that we would need in that regard. And pharmacists can play a very key role in that. In fact, in Nigeria, we started with a group of pharmacists to create a national policy for how to increase access to controlled medicines in a medical setting so that people can relieve pain in a safe and regulated system. On the other side of the house, you see the pillar is education and training. And that education and training is clearly for people coming into the system. So pharmacists, new pharmacists, but it's also about continuing education because we are constantly making the changes within the protocols, within the needs of the patients, all of those kinds of pieces. And, I give a big shout out to FIP for supporting that pillar in such a nice way, and being a leader in that part of the education and training. And then the roof is really, what does it look like when we integrate? How do we think about palliative care from that interdisciplinary approach as early on as primary health care, and all of the pieces that come within a systemic approach. I want to talk briefly again about how does this look if you're doing it in your country. What you want to do is do a needs assessment. And again, pharmacists play an important role in understanding and knowing what needs patients have, and the number of people who may be trying to access pain management, who have long-term illnesses. And so please do be thinking of yourself in that research piece, and also in the promoting health policies. So that needs assessment is key. It's also important when we go into countries and we're looking at how do we put a system in place, that we look at the health policies and we do legal documents. So what kind of insurance policies and schemes are available? What's the situation for particular diagnosis, for cancer, for HIV, for tuberculosis, for dementia, for NCDs? Are there special circumstances? It's really important to get key informants. So we go to each piece of that interdisciplinary team to ask them, how are things going? How can you contribute to palliative care services? It's not just looking at the numbers, it's also looking again from that integrated approach. And so pharmacists, need to be at the table, they need to be involved in that conversation, and they need to help in developing national standards, because your contribution in terms of medication management is critical. I'll give an example of a country where they did not have in country any pain medication, or I should say they had enough pain medication in country to serve one cancer patient for a week in the United States. And that is what that country had imported for a year for a population of 1 million people. And so looking at that just doesn't fit. That just does not allow for people to have that quality of life and for the reduction of suffering. And then, of course, once you do that needs assessment, then you really want to look at developing some policies. We're looking for high standards. We're looking for what do you put in place for a national strategy, an action plan, again, not going into details today, but knowing that you want to be able to define what is palliative care, what is that interdisciplinary team, what is the cost savings for integrating that interdisciplinary team, managing pain and suffering without having a person taking a hospital bed, or without having that person go into an emergency room visit on a regular basis. So taking the burden off of the hospital services and having a number of, having care be administered in the home could certainly be, in most cases and in most countries, a cost savings for the larger healthcare system. And then what you want to do is to be able to, with that system, put it into play. Pilot it perhaps in a small place, a small area, a small region, and then move that forward. Again, I'm available for questions about the system in more detail, but I also would like to move on to my last slide. Okay, there we go. And just remind people as you're listening to the next speakers that it really is about addressing the physical, mental, emotional, social, and spiritual needs. And pharmacists play a key role in each of these areas. If you think about a person that is in pain and they're coming to the pharmacy for medication, You can see that they look like they are in pain. You can hear in their voice that they may feel depressed. They may, look down. You know if they have someone who's helping care for them. You know if they come in with someone. You see that person in person regularly. So you have the opportunity to ask some questions, to intervene, to suggest that they reach out to a spiritual guidance. Um, the things that I want to highlight before I'm finished. One, thank you, Betty, for the shout out for the World Hospice and Palliative Care Day this Saturday. Please do go to our website. If you have an event or you're doing something, please make sure that you register that event on our website. Think about integration. Think about high standards. This is an interdisciplinary effort that should be at the highest level of each piece of that team. And access to medication is critical. There's still only 5 places in the world where people really can access pain management adequately. And so I urge you to be a part of the conversation about increasing access to pain management and essential medications. And with that, thank you, Betty, for the time.
Thank you, Elizabeth, for your insight and for that depth of experience. It really was amazing talk. I have the pleasure now of introducing you to Dr. Eileen Haj, who is the global lead for FIP's Development Goal 10 Equity and Equality, and a clinical pharmacist with a PhD in pharmacology from Paris Descartes University and St. Joseph University of Beirut. She is currently an associate professor at the Faculty of Pharmacy, Laval University in Canada, with extensive expertise in clinical pharmacy, pain management, and pharmacogenomics. Dr. Haj has authored over 115 scientific articles and delivered more than 100 international presentations. Eileen has contributed to the initiatives highlighting the pharmacist's role in holistic patient care, particularly in oncology and palliative care, and has led interdisciplinary projects bridging clinical practice and health outcomes. Her research focuses on the development of precision and innovative strategies for comprehensive pain management. Dr. Haj is a member of INSPECT LB, the Quebec Research Network in Palliative and End-of-Life Care, the Quebec Pain Research Network, and the Cancer Research Centre and Network, reflecting her commitment to advancing patient-centered care across multiple clinical and research domains. Dr. Haj will now talk to us about optimizing palliative care for older persons, the pharmacist's role and clinical impact. Thank you very much, Dr. Haj.
Thank you so much, Betty, and thank you for the FIP for allowing me to be with you today to discuss how we can optimize the palliative care for all the patient and what would be the role of the pharmacist in that with the clinical impact as well. So I'm really happy to have my presentation just after Elizabeth's presentation because she introduced a lot of the concepts I would like to discuss today. But I will go over highlighting some important things related to palliative care, and then I will explain better why palliative care needs pharmacists and what we can do on a daily basis in all settings. So as we know, nowadays we have more older adults that live with multiple chronic illnesses and complex needs. These patients would have dementia, functional decline, and we have this cultural and social diversity that adds to the complexity of what we can do, what we can expect from palliative care. So all of that would add pressure also to the health system. Much of the burden is carried by the primary health care. And if we want to like have a quality, continuing, and patient-centered care, you can understand how increasingly challenging it became. So palliative care is not optional at all. It is really essential. And the pharmacist role in palliative care is not optional as well. It is essential. So we will see during this presentation how we can optimize the symptom management, manage polypharmacy, deprescribe, ensure the planning, safety, and all collaborative things that we can have with the primary care team to meet the patient's goal at the end of the day, definitely. So if we go over the definition of palliative care that was published by the WHO, why it is important to check, because we need to understand that everything that we do in palliative care allows us to improve the quality of life of patients and their families. This is a really important thing, that are facing a problem that is associated with a life-threatening illness. So it is not only to relieve, but it also to prevent the suffering. And I will talk in a moment about the suffering compared to pain. To do an early identification. This early identification is really important as well. And to do like a correct assessment and treatment of pain. And as Elizabeth said, whether physical, psychosocial, or spiritual. So as you can see in this figure, it is important to remember that palliative care is not at all an end-of-life setting. We can do a lot before. So as you can see on this figure, when we talk about death, it's like where we have the screen shadow. So this is death, but you can see that since the diagnosis of a chronic life-limiting illness, we can do a lot during this journey of the patient. And it can be with the new treatments that you have, whether immunotherapy, whether targeted therapy for cancer or other treatments. We know that we can expand this time since diagnosis until death, and we can do a lot during this palliative care journey of the patient. So it is important to remember that we can support the patient at any stage of his serious illness. So moving forward with other international guidelines, this question of early intervention is really, really important. Even if we look at the guidelines of oncology guidelines, you can see in the recommendation, they talk about the early integration within the continuum of the disease. We need to help the patient earlier during his journey to help him manage and alleviate the symptoms, whether the stress, as you can see, the functional status related to pain, fatigue, sleep disturbances, mood disturbances, and all other things. And this should be performed definitely with the coordination with other care providers, and how we can have referral. The pharmacists play an important role in the referral to other care providers as indicated. So even if we look at the definition of the International Association for the Study of Pain, pain is not anymore like just the physical. Even the new definition of the ASP, they define that pain is much more than that. It involves different biological, psychological, and social factors. It is an experience, and our role as pharmacists is to improve this experience and to learn from their experience to be able to help them better. So when we look at pain, or we think, is it pain or suffering? It's not only pain, it's much more than pain. So we're talking more about the suffering. We're talking more about this holistic approach to help him relieve the suffering, because the patient would have, yes, we would have a physical pain, but he would have also anxiety, depression, fatigue, cognitive impairment that impairs his social and professional life, sleep disturbances, and we don't have to forget everything that is related to pain medication with the risk of addiction. And in all this perspective, we always ask ourselves, so what would be the role of the pharmacist in palliative care? Do we have challenges, and how we can overcome them? Yes, we have challenges, and we will see how we can overcome them. So the pharmacists play an important role in this whole service. So as you can see in this figure, you have the patient at the center and the core of our approach. And the palliative core would involve a range of services that would have equally important roles. And the pharmacist is listed among these to help them have a significant role to support not only the patient, but also the family. So when you look at what we can do as pharmacists, so you have to remember that it is complex to achieve. It is complex because actually we have complex and chronic symptoms and clustering that require tailored management. We have highly variable profiles and disease trajectories among different illnesses. The symptoms are usually undiagnosed or difficult to assess. We have a need like to balance symptoms with medication side effects. We have to the challenge with medication adherence to treatment, especially in patients with dementia and cognitive disturbances. Some therapies would worsen some symptoms. We have frequent hepatic and renal impairment that affect dosing and safety. And one important thing is about polypharmacy and the high risk of drug interaction. And some studies reported even like 20% of patients would have more than 8 medication on a regular basis in a palliative care setting. So you can see the importance of addressing all these issues. So how we can address them? I really love the concept of the 7-star pharmacist that was developed by the WHO, where we can remember that the pharmacist is not only a provider, he's a caregiver, he's a good communicator, good listener. He can communicate with not only with the patient, but also with his family and with the other member of the team. He's a decision maker, he's a teacher, and I was happy to see that the pillar of the new model that was suggested by the WHO is about research. So yes, the researcher is important. And all these roles of the pharmacist would allow him to take into consideration the physical, psychological, social, and spiritual health of the patient. So in this complexity, the pharmacist play an important role because he is in close contact with the patient and family, whether in different settings. He ensures that the medication is available, especially in low resources countries, or eventually where we have like some shortages in medication. He will be able to manage drug preparation and stability, and he is the pharmacotherapy expert, so he can personalize the follow-up. He could optimize the treatment considering age-related changes. He can evaluate not only effectiveness, but also safety, and he can support treatment adherence with patients, as I said, with dementia or other cognitive disorders. So that's why I love to add to the definition of the WHO this question of the throughout. So we have to improve the quality of life throughout all the continuous of illness. And we have to address, as I said, physical, intellectual, emotional, social, and spiritual need to be able to facilitate autonomy, access to information. So we have a major role to play in information and the choice. It should be a shared choice by the patient and the pharmacist and his team to decide what is best for him. And that's why it is an evolving role of the pharmacist. Definitely we have some disparities all around the world, but we have also guidelines that would help pharmacists to improve their role in palliative care. So is it a simple role? No, but the FIP also highlighted the development goals, and I can tell you the pharmacist that is working in palliative care could have plenty of things that he can do. Since he is a medicine expert, he's working with others, he's being able to address and advance integrated services, especially in palliative care settings, to provide the people-centered care and improve the patient safety. So we have a very much important role to play in implementing palliative care strategies and programs to make impact and beneficial outcomes. So when we're talking about impact, I will talk about the clinical impact in a moment, but I would like to highlight also the societal impact. The societal impact, because we're not only replying to the patient, we're checking this idea within a global framework that is the global framework of the SDGs, so the Sustainable Development Goals, because we're not only ensuring a good health and well-being of patients, but once we are helping the patient and his family, we're adding some quality education, we are reducing inequality in access to care, and we are allowing these patients with palliative issues to be able to get back to work and have a decent work and contribute to economic growth. So after talking about the societal impact, what would be the clinical impact? The clinical impact it is really like why to discuss about all the clinical impact that the pharmacist can have. But I tried to like check from the literature and the research, what are the like evidence-based practice that we might have. So it could be related to the direct patient care. It could be related to the medication review and reconciliation, education about medication and how we can best counsel our patients, and have definitely the administrative role. All of that, as I told you, to have an evidence-based, safe and effective medication use, and to be able to develop each one of us a personalized and a patient-centered care plan. So we can optimize symptom management and treatment outcomes. We can play an important role in dose adjustments and administration optimization, including alternative routes of medication for the end-of-life settings. We can have patient counseling, medication adherence strategies. We can identify and resolve some medication-related problems, especially what is related to abuse or misuse of some medication for pain, such as opioids. We can have therapeutic follow-up to ensure efficacy and side effects. And we should not forget that we're working within an interdisciplinary team with other healthcare professionals, especially within the transition of care, where the pharmacist can play a really important role. So I'll give you some examples and some like real world data from clinical impact of the pharmacist that he played during this palliative care settings. So first of all, one of the most important things when we talk about palliative care in elderly, it is about polypharmacy. We know that polypharmacy is associated with a reduced quality of life, with a greater pill burden, increased risk of drug-drug interaction, and definitely increased risk of adverse events, falls, and even death. So if a pharmacist is playing a role in deprescribing, what does it mean, deprescribing? It means that we have to identify, to discontinue medication that have potential harm, and they no longer provide benefit, and they are no longer in line with the patient's goal. So this is where we can improve the patient quality of life and all the risks that are associated. And I can tell you that in some countries, such as in Canada, we have some laws that expanded the scope of practice of pharmacists, where they can play a role in the prescribing adjustment, deprescribing, and lab follow-up. So what do we have? Some results from the literature, and you have, as you can see here, you have I've chosen for you two recent studies from 2014, 2025, and 2024. So as you can see, this is an implementation deprescribing assessment that showed that the pharmacist was able to do 3.4 deprescribing recommendation per patient. These deprescribing recommendations were highly accepted by patients and caregivers. And they concluded that the pharmacists play an important role in assessing and implementing this deprescribing. Another study has shown also that if we integrate the pharmacists not only in deprescribing, but also in this transition of care, they will play an important role in reducing medication errors in complex risk, high-risk populations such as elderly population. And not only it is valuable, but it also is feasible, so we can do it. Other issues are related to pain medication and pain management. So also in the literature, we have very important studies that showed, also new studies from 2024 that showed the clinical impact, while the clinical pharmacist intervention helped improving quality of life, reducing anxiety and depression, and enhancing medication adherence among cancer patients. Other studies from optimizing opioid medication, also they said they have shown, this is a systematic review that showed that the role of pharmacists in palliative care improve patient outcome and the overall quality of life of patients. A qualitative study, really interesting, also explored how the pharmacists can play a role in the rural setting, so in patients that are underserved. And they showed that the model of integration of a palliative care pharmacist within this setting showed that it gives a patient this choice. It showed that the pharmacist is a trusted source for support and information. They improve medication knowledge and decrease of burden. The communication has been increased and enhanced. They have been a benefit for healthcare professionals, but also reducing workload and stress over that. And we have a reduction in disparity. So this is a very, very important thing to add as well. So is it easy to do it? Yes, we have a vital role, but to enhance the quality of life, but we need a greater education, training, improve interprofessional communication, improve access to patient information. So, and definitely we need, like, as Elizabeth said as well, we need to have policies to support and strengthen the role of the pharmacist in palliative care settings. So that's why I would like to conclude with 1-2 minutes just to talk about the golden strategy that we can implement as we're doing today with the FIP. And this is another shout out for the FIP for supporting education all through the world. So education in palliative care is important. But why we need why we need education first? Because, as I said, we have inequity in access to palliative care. We have also disparities across the world in pharmacist practice, workforce, preparedness, education, and research in palliative care. And that's why it is important to have adequate national policies in each country with programs, resources, trainings on palliative care among healthcare professionals. This is urgently needed to improve access to palliative care all through the world. But I can add as well that education should not only be for pharmacists, education should be at all levels, at the level of the public, at the level of the patient, the providers, and the policymaker, so they can understand the importance of having a pharmacist within this scope of practice, to have a patient-centered management, optimize patient outcome, promote appropriate use of medication, and reduce the risk associated, for example, with all medication, but also specifically in prescribing opioids. So if we have this education with an effective patient-centered care, with eliminating stigma related to palliative care and palliative care settings, to reduce risk through this risk assessment, I can ensure that we can do a lot by education. And we can't only say that the pharmacist would play a role and the clinical impact, but palliative care needs pharmacists, and we can't have palliative care without pharmacists. Thank you so much.
Thank you, Aline. That was an amazing talk. I'm sure there's a lot to take on and think about and reflect. We'll come to the Q&A later. I'm sure there's lots of questions about what you've added to the WHO structure. It is another great pleasure of mine to introduce you to Associate Professor Gizem Gülpinar, who is an associate professor at Gazi University, Turkey, and senior research advisor at the Commonwealth Pharmacists Association at the UK. Her work focuses on pharmacy leadership, ethics, and implementation science, with a particular interest in communication skills, moral reasoning, disaster pharmacy, and supporting pharmacists' role in patient-centered care. All of this is music to my ears. So thank you very much, Gizem. Over to you, my friend.
Thank you, Betty, for your kind introduction. Good afternoon, everyone. And thank you for FIP for this invitation. It's a real honor to join you for this important webinar, especially as we mark World Hospice and Palliative Care Day. My focus today is going to be something that often seems simple, but in reality is incredibly complex communication, specifically how pharmacists can build trust and support patients through communication skills in palliative care. As pharmacists, the science of medicines, but in palliative care, our role goes far beyond pharmacology. Here, our words, our listening, and even our silences can be as therapeutic as the medicines we provide. Okay. In pharmacy, we often think of communication as an add-on, something we do after we've made the clinical decisions. But in palliative care, communication is not an accessory. It's at the central to care. For patients, the way we communicate shapes their entire experience. A calm explanation can ease their pain, or a dismissive tone can deepen their fear. It works as for the caregivers. Our clarity and empathy give the caregivers to support their loved ones at home. So communication also builds trust, and this trust is vital across care decisions, from hospital to community, from home to hospice. Pharmacists are often the consistent presence in these journeys. So our words and guidance can anchor patients and their families. And finally, communication is what allows us to function as part of an interdisciplinary team. Doctors, nurses, social workers all bring their different expertise. So for pharmacists, communication ensures our voice about medicines and safety is heard, and that our contribution translates into better outcomes. So when we ask, why does communication matter in palliative care? The answer is simple, because it's not just what we say, it's what patients and their families carry with them along after the conversations end. I'd like to present a figure here. It's illustrating what effective communication looks like between the patients and the providers. On the left-hand side, you can see patients bringing their own beliefs, needs, values, and skills. On the right-hand side, you can see the provider, that's us, Pharmacist, brings us our own professional knowledge, but also our beliefs, communication style, and experience. Both sides interpret and convey some messages shaped by internal factors such as experience and external factors like time pressure, environment, or family dynamics. So the key idea here is that communication is a dynamic process. It's bidirectional. So the provider isn't just transmitting the information to patients. We are constantly interpreting and adjusting our messages based on patients' reactions and feedback. Likewise, patients aren't just recipients. They are actively influencing the conversations through their body language or their feedback. In palliative care, this model is particularly powerful because it reminds us that empathy, active listening, rapport building are not separate skills. They are what make this two-way process work. Through active dialogue, we can move from telling patients what to do to understanding what matters to them. So I'd like to mention a bit about emotional and psychological aspects in palliative care. In most of our day-to-day pharmacy practice, emotions are present, but usually sit in the background because a patient might be frustrated about waiting times, anxious about side effects, but our conversations are primarily focusing on treatment. But in palliative care, that balance shifts completely. Here, emotions move to the center of the conversation because patients may live with fear about pain, about the unknown, or about being a burden. Some of them may be in denial about their diseases. Others may feel anger at the disease, at the loss of their independence, or even at the healthcare system, as it was mentioned. Families experience what we call anticipatory grief, which means mourning long before death occurs. And caregivers often supposes and children are having enormous responsibility here. They face exhaustion, burnout, guilt, wondering if they're doing enough. Emotions are essential here because emotions directly influence how patients engage with their care. Patients who feel fear may not, report symptoms honestly, or caregivers who feels overwhelmed may not follow instructions properly. So our role, of course, is not to solve these emotions. We're not counselors, but we can acknowledge these emotions. Sometimes a phrase such as, "It sounds like this is really overwhelming," can make patients feel less alone. When we think about communication in palliative care, we must remember that emotions are not a side issue. Sorry. Empathy is another important tool that we have on our hands. Empathy is often described as walking in someone else's shoes, but in healthcare, it's also showing patients that we see their struggles and we're standing with them. Empathy is the foundation of trust. For the average patient, we can say that empathy might mean showing we understand their frustration with a side effect or a daily problem. But while we talk about the palliative care, it takes on an entirely new depth. In palliative care, patients, as I said, might be coping with more of an existential problems. A sympathetic statement like, "I can see this is really hard for you," validates their feeling. So empathy here is not saying the perfect words. It's about just presence. And sometimes it can be just a silence, just staying with them in their pain. These moments of empathy are remembered long after the consultation ends. And importantly, don't forget that we can practice empathy by slowing down, noticing the emotions and responding compassionately. We cannot talk about palliative care without talking about active listening. Active listening is the partner of empathy. We can say that active listening is the skill that patient can understand that we show empathy. Patients often tell us things indirectly, through their hints, or it might be some pauses. And if we're rushed, we can miss them. As we as pharmacists can listen our patients actively in several ways. It covers some steps that we need to pay attention. First, we need to give full attention to our patients, putting aside all the distractions and making the patients feel like they are the only person in that moment in that consultation room. And secondly, we can ask open-ended questions like, what's worrying you most right now? Or how are you coping with your medications? Questions that like this can invite some stories rather than just providing yes or no answers. It also opens, active listening also opens some doors to reflecting what we've heard. Like, so you're saying the pain is worse at night, is that right? This shows patients that we've not only heard them, but we've understood them. Just as importantly, it's about just acknowledging the emotions. Silence is another significant tool that we can use under active listening. Sometimes patient needs some spaces to process or to find the courage to say what's on their mind. And finally, we have to pay attention to nonverbal cues. Eye contact, nodding, open posture, tell the patients and caregivers that we are present with them. So active listening matters in several ways because patients often carry unspoken fears. If we don't listen them actively, we may never hear these concerns. And when we do, we can tailor care in the ways truly match the patient's values. So active listening also strengthens our connection with the caregivers, with the care team. And please don't forget that active listening is not a soft skill. It's one of the most powerful clinical tools that we need to learn to use in palliative care. Another important aspect here is that building rapport. Rapport doesn't happen overnight, but it grows from consistent, respectful interactions. Rapport is what turns communication into a real relationship. It's about establishing trust and mutual respect, and patients need to feel that we genuinely care about them as people, not just as cases. It's the sense that this professional or this pharmacist understands me and I can rely on them. Rapport covers several things. First of all, an authentic interest should be at the center and across the patient as a person, using their name, remembering small details about them, and showing reliability. These create a continuity and security. Respecting autonomy and dignity is another key in building rapport. Even if we disagree with a patient's choice, involving them in decisions shows respect for their dignity. And of course, caregivers shouldn't be forgotten in this picture, because they are the active partners in palliative care. Including them in conversation, acknowledging their role, and supporting them strengthens the whole circle of care. So rapport matters in several ways as well, because patients are at their most vulnerable. Trust can be fragile in palliative care. If rapport is strong, patients are more willing to share their fears and even the difficult questions they may not raise otherwise. So it's too important to pay attention building rapport. And I would like to give some practical tips for sensitive situations here, because in palliative care, some of the most important and most difficult moments are sensitive conversations, stopping a long-used medicine, explaining that a treatment has reached its limits, and managing unrealistic expectations. These are not easy tasks. The keys here are clarity, honesty, and compassion. It's important to avoiding jargon. Using simple words, understandable language are key here. We can pay attention to not offer false reassurance, but also avoiding bluntness. this might give us some short-term relief, but damages long-term trust. So instead, we might strike a balance here. We can say, like, we may not be able to stop your illness, but we can absolutely help you feel comfortable. So these are the moments when our words becomes as powerful as medicines, because they help patients and their families face reality with dignity rather than fear. And we shouldn't forget cultural sensitivity here, because each patient bring their own values, own beliefs, and ways of approaching end-of-life discussions. Let me share you some phrases that I found transformative in practice. These are simple words, but they have the capacity to open doors. For example, saying, "I can see how difficult this is for you." It acknowledges suffering without any judgment. It doesn't offer false assurance, and it doesn't minimize the pain. Instead, it says, "I hear you, and I can see you." And often, that is exactly what patients in palliative care need most. Asking like a question, "What matters most to you at this stage?" shifts the focus from disease to person. It says you are more than your illness. And saying, "Let's explore this together," change the power dynamic. It shows some partnership, that the patient and caregivers are not alone in this journey. And would you like me to explain all the options, including what we can and cannot do? This balances honesty with empowerment, and if it offers some transparency, but just with respect. Of course, these are not phrases. These phrases are not some scripts that we need to stick with. These are just examples of language that creates trust and dignity. We can all adjust these type of phrases into our own context. And in palliative care, these qualities are just as healing as any medicines and any prescription. We cannot talk about palliative care without mentioning caregivers. They are often the invisible backbone of care. They give medicines at 2 a.m. They absorb the emotional pain, often while holding back their own grief. Our communication with them matters as well. A simple acknowledgement like, "I see how much you are doing for your loved one," and can bring enormous relief. Clear and importantly, written instructions help them feel capable rather than overwhelmed. At the same time, it's important that we must remember to respect patients' autonomy at this stage, because sometimes caregivers want to take over decisions, but unless the patient has given that role, we should remember that patient's voice is central. Offering caregivers resources like leaflets, support groups, helplines, printed guidance can ease their burden. To ground what we've discussed so far, I'd like to highlight a recent systematic review published in 2023. They analyzed what effective communication in palliative care truly means from the voices of patients and their relatives. The study found that communication is most effective when it's a dialogue. Patients and families want to be part of a genuine exchange where they can express their feelings, questions, uncertainties freely. It also found that empathy, openness, and trust are essential, are at the central stage. Patients and relatives valued clinicians who communicated with emotional awareness. The review also emphasized that caregivers must be recognized as active communication partners, not passive listeners. And overall, the study concluded that effective communication care in palliative care fosters emotional safety, satisfaction, and shared decision-making. Another study explored some barriers at 3 levels. At the consumer level, fear of death, denial, cultural and language differences made conversations difficult. And at the provider level, discomfort, lack of training, and time constraints limited proactive communication. And at the system level, conversations often happen too late, and the gaps in reimbursement or policy support prevented consistent communication practices. What's more striking is that both studies converge on the same message. Effective communication in palliative care requires both compassion and structure and policy. We need empathy to connect, but also some time, tools, and trainings to make those connections sustainable. Together, these findings remind us that good communication doesn't just happen. It's just a skill, a process, a system, and a culture that we must intentionally build. I'd like to pause here to highlight a resource I believe in strongly, FIP CPD Bites on strengthening trust, empathy, loyalty in pharmacist-patient interactions. I'm mentioning this resource here because communication isn't just a skill we learn once and put aside. Every patient, every culture, every family teaches us something new. They're not long These are not long courses. They are some bite-sized, evidence-informed, and very practical for professional development. They are designed for busy pharmacists who want to keep improving communication, trust, and patient-centered care. One recent episode called Beyond Medication Strengthening Trust, Empathy, Loyalty in Pharmacist-Patient Interactions is especially relevant to what we've been discussing today. It offers concrete examples of how small changes in language and presence can build trust and loyalty. So I strongly encourage you explore CPD Bites. Pick one episode, try one strategy from it in your next patient interaction and reflect on what has changed. That cycle of learning, applying, and reflecting is how communication becomes part of the art of pharmacy. So what we can carry forward from today, first I should say that palliative care, communication, isn't just a tool to support the treatment. Communication is the treatment because the way we speak, way we listen and connect has direct impact on dignity, trust, and connection. Secondly, empathy and listening are transformative. They create the space where patients feel safe and which improves even the outcomes. Third, rapid gives patients and families safety to open up what they fear and what they hope for. And caregivers are not an afterthought. They are at our central partners. And finally, we as pharmacists have unique roles to play. We prescribe when medicines no longer serve. We guide safe use and disposal. And we provide continuity across care decisions. These are critical responsibilities, and our communication skills make them possible. So if you remember one thing from today, from my presentation, let it be this: the science of medicines and the art of communication are inseparable in palliative care. Together, they allow us to bring not just knowledge, but humanity to our patients and their families. Thank you for your attention. Palliative care is one of the hardest areas of the practice, but it's also one of the most profoundly meaningful because as pharmacists, we have the privilege of walking alongside our patients and families at a time when trust and empathy matter more than ever. I very look forward to your reflections and questions. Thank you very much.
Thank you, Dr. Gizem, for a beautiful presentation. Very, very thoughtful. It gives me great pleasure now to introduce you to Mr. Darren Walsh, who is going to talk about pharmacist interventions in cancer-related palliative care. Darren is a geriatric oncology pharmacist and a PhD candidate and a guest lecturer in the School of Pharmacy, University College Cork, as well as a guest lecturer in the School of Pharmacy and Pharmaceutical Sciences in Trinity College in Dublin. He has experience in aseptic compounding and clinical oncology, hematology, pharmacy. Darren has also expanded his practice, focusing on supportive cancer care, leading to roles on both the geriatric oncology and palliative care multidisciplinary teams. In 2021, Darren commenced his PhD project titled Evaluating the Impact of Pharmacist Interventions in the Geriatric Oncology Setting. In 2023, Darren joined the Southeast Palliative Care Centre. It's just 1 second, sorry. Joined, and in 2021, no, that was the commencement of the PhD. In 2023, Darren joined the Southeast Palliative Care Centre Medicines Management Committee. Darren is a member of the International Society of Geriatric Oncology, the British Oncology Pharmacy Association, the Irish Pharmacy Haematology Oncology Society, and the Irish Association of Palliative Care. He's a member of the National Cancer Control Program, Steering Group for Geriatric Oncology, also the chair of the Hospital Pharmacist Association of Ireland Education and Research Specialist Interest Group. I now hand over to Darren for his talk.
Thank you, Dr. Chaar. So today I'm going to be discussing pharmacist interventions in cancer-related palliative care. So hopefully by the end of this, I'll try and get this done within 15 minutes. So we have time for questions where you'll be able to understand how palliative care can integrate with oncology pharmacy, implement best practices in opioid management for cancer pain, outline safety considerations in relation to chemotherapy and supportive care, and also as well practice people-centered approaches in advanced cancer care. So pharmacists play a key role in the medication management of patients with advanced cancer. And patients with advanced cancer, how we look at it here in University Hospital Waterford and in the Southeast Palliative Care Centre, is 3 distinct categories of medications. There's systemic anti-cancer therapy, which in advanced cancers with palliative intent, so this may include chemotherapy, hormone therapy, targeted therapy, immunotherapy, etc. They also take supportive care medications. So these can be medications for the prevention of systemic anti-cancer therapy toxicity, so prophylaxis for chemotherapy-induced nausea and vomiting, but also for the treatment of that toxicity. So if a patient has breakthrough nausea and vomiting, we use antiemetics to treat those. And Dr. Haj mentioned earlier about the heterogeneity of cancer patients. So again, what we do here is we do a lot of individualized antiemetic regimens for patients to match their comorbidities, but also the treatment of cancer-related symptoms. So in our geriatric oncology clinic, we see an awful lot of patients with upper GI or pancreatic cancer, and 87% of those patients we know from the literature will have cancer anorexia cachexia syndrome. And olanzapine is the first-line agent as per the American Society of American Society of Clinical Oncology guidelines for cancer anorexia cachexia syndrome. So therefore, it's good that we know the evidence to that so that we can identify that a relatively cheap medication can be used to treat a complex palliative symptom. In addition to this, patients will be taking medications for their chronic conditions and comorbidities like antihypertensives, antihyperglycemics if they have diabetes, or as required medicines like paracetamol or acetaminophen for occasional pain, antihistamines for seasonal allergy, for example. And the role of the pharmacist is to optimize the blend of these medications to optimize therapy for patients. So an example of this would be if we do use olanzapine for cancer anorexia cachexia syndrome, we know from our colleagues in psychiatry that they use metformin to halt the weight gain associated with atypical antipsychotics. So if we have a diabetic patient who's got an upper GI cancer and requires olanzapine for anorexia cachexia, we need to stop or change their metformin to ensure that they actually get the benefit of olanzapine while we're treating a patient, a vulnerable, frail patient, with a medication in itself with a significant adverse effect profile. Oncology patients have complications that do require palliative assessments. This is this is data from an excellent publication by Chloe Erledan and colleagues in Lyon in France in the Journal of American Geriatric Society. And when they look at the cause of hospital admissions in a cohort of French older adults with cancer, there was 10 predominant causes, one which is grouped as other causes, but 6 of these ultimately will have pharmacological interventions that will be palliative in nature. So deterioration of general condition, dyspnea or COPD exacerbation, pain management, fall, bowel obstruction, and renal failure all will be managed pharmacologically in some sense with palliative pharmacotherapy perspective. So therefore, it's really, really important that oncology pharmacists and pharmacists caring for people with cancer are aware of the palliative pharmacotherapy associated with that. So if we stick with pain management then and focus on opioids and optimizing opioid use for cancer-related pain, the majority of cancer-related pain is opioid responsive. There are exceptions to this. Some cancer-related bone pain due to skeletal-related adverse events can be quite difficult to treat with opioids and maybe non-opioid responsive, but most cancer-related pain is opioid responsive. And once opioids are titrated appropriately and used under specialist supervision well, there are generally absolutely no contraindications for opioids in cancer-related pain, especially in patients with advanced cancer. However, the role of the pharmacist here is key in terms of determining that opioids are always renally or hepatically dose optimized, and there may be a preference for one opioid over another in some clinical circumstances. So in our patients who develop end-stage renal failure, like we had in the previous slide, if they're on morphine, which accumulates in renal failure, we may want to rotate them to a different opioid that undergoes hepatic metabolism, for example. And opioids act on 4 main receptors, mu, delta, kappa, and NOP. But mu is the clinically relevant one that we're kind of primarily focused on. So mu receptors are their effector mechanism is the cause opening, the stimulate G proteins that cause opening of potassium channels, and this is responsible for some of the opioid effects. Ultimately, all clinically important opioid analgesics act as agonists on the mu opioid receptor. Some opioids, in particular buprenorphine, has partial agonist activity at the mu opioid and NOP receptor, and buprenorphine is an antagonist to kappa and delta opioid receptors, which means that when you are starting somebody on buprenorphine, you get some antagonism at kappa and delta. So if they're established on an opioid, there is a small risk of withdrawal. If they're established on buprenorphine and you introduce an opioid, that risk is negated. And at usual analgesic doses, buprenorphine will act as a full mu agonist, but it will not occupy all of the analgesic receptors. So there is scope on occasion to introduce further opioids in a patient where we're worried about escalating to too high a dose of buprenorphine. Undesirable effects generally relate to both central and peripheral mu opioid receptor activation, mainly in the CNS and GI tract. And methadone, tapentadol, and tramadol have some extra opioid effects. Methadone blocks presynaptic uptake of serotonin and NMDA receptors. Tapentadol blocks noradrenaline, and tramadol blocks both serotonin and noradrenaline. And this is the mechanism why drugs like methadone and tramadol are not ideal with monoamine oxidase inhibitors, because they can contribute towards serotonin toxicity. When we have someone established on an opioid and we need to change them to a new opioid because of maybe toxicity or tolerance, or maybe we need to switch from oral to parenteral opioid administration, we should be using conversion charts. So this is an example of a table from the conversion chart produced by the Palliative Medicines Information Service and Our Lady's Hospice and Care Services in Harold's Cross in Dublin, so the Irish National Palliative Meds Info Service, and it gives information on how to switch from oral morphine to other opioids, oral opioids to their parenteral equivalent, parenteral morphine to other opioids, and transdermal opioid to oral morphine. So when we're switching, we need to know the available equianalgesic dose data, the clinical condition of the patient. So I come back to making sure for switching opioid to a patient with end-stage renal disease that we're switching to one that is not renally accumulating. What are their concurrent medications? We may be switching from a drug without drug interactions with the concurrent meds to ones that may have. So methadone prolongs the QT interval, for example. And we also want to take into account patient safety. Earlier on, Dr. Matfield talked about education and training of healthcare professionals, but also here educating and training caregivers and patients into how to administer maybe a new formulation of an opioid that they're taking. And usually we would reduce the dose by 30 to 50% if we're switching from one opioid to another to allow for incomplete cross tolerance with changes in hepatic renal function, inter-individual changes in pharmacokinetics and pharmacodynamics. But if we are trying to escalate a dose but rotate at the same time, the clinical decision may be made not to make that concurrent dose reduction and to observe. And that is typically kept for the inpatient setting. People on a background opioid will experience breakthrough cancer pain, and that's commonly treated with a PRN or an as required dose of an immediate release opioid, which is traditionally 1/6 of the total daily opioid dose, and 1/10 to reduce the risk of adverse effects. And a standard fixed dose will not suit all patients and all pains. So as was mentioned earlier, the intensity and impact of breakthrough pain will vary considerably. And when prescribing an as required dose, it's recommended that a maximum daily amount is stated. If 2 different routes are prescribed for breakthrough pain, so oral and subcutaneous, for example, they should be entered separately because of different because of the change in bioavailability. And patients' carers should be taught how to use each formulation correctly, and the amount of use should be reviewed regularly, and when necessarily, the background analgesia increased. Moving on then to some safety considerations for systemic anti-cancer therapy. Typically, when we're handling systemic anti-cancer therapy in palliative patients or in oncology patients, we do a risk assessment. So we want to identify the hazardous properties of the drugs we're handling, the risks associated with the hazard, so who may be harmed and how, and also the rate of the risk. So how likely is it that the drug could cause ill health if people were exposed to it unintentionally? And then we need to identify if our control measures if additional control measures are required, or if we need to implement more control measures. And this typically is a continuous process, which involves continuous risk assessment, auditing the compliance of safe work, checking employee competencies, and reviewing data for near misses to continuously upgrade this safety material for handling systemic anti-cancer therapy. And some employees are at greater risk than others, as you can see here. But with individual drugs, the risk of other personnel may be increased. So laundry personnel is in the lower risk here. In the inpatient setting, somebody who receives cyclophosphamide, which is excreted in sweat and saliva, may put laundry personnel at higher risk. So they may require education in handling the laundry materials for that patient. In the community setting, patients may develop swallowing difficulties, particularly those with upper GI malignancies, or as well, or patients with breast and lung cancer or typical lymphomas that will have a lot of lymphadenopathy in their chest area. So they may develop swallowing difficulties that they don't have at baseline. So as their treatment progresses, they may require administration of oral systemic anti-cancer therapy via enteral feeding tubes. And the British Oncology Pharmacy Association have some really, really good guidelines on taking into account all of these considerations. If we look then at some safety considerations for supportive care, I use the example here of irinotecan, which causes diarrhea in patients. And irinotecan, predominantly here on the left of the screen, you can see is used. These are the Irish protocols for irinotecan for treatment regimens that contain irinotecan. And it's in the majority of cases, it's actually used in the metastatic setting, so in the palliative setting, with the exception being adjuvant pancreatic cancer. Irinotecan diarrhea that is caused by irinotecan has two main mechanisms of action. The first one is early onset diarrhea, which is within 24 hours of irinotecan being commenced, and that is cholinergic syndrome. So it's hyperactivation of acetylcholine, and that can only be treated or prevented using cholinergic medications. So we use prophylactic atropine sulfate subcutaneously. Diarrhea that occurs after 24 hours is late onset diarrhea, but the risk factor for the cholinergic syndrome, the early onset diarrhea, are female sex and high doses. But the irinotecan regimens that we use would use doses at this level. And irinotecan cholinergic syndrome is characterized by that early onset, so establishing a clear timeline is essential. But also then, because you're hyperstimulating acetylcholine, you'll get sweating, cramping, lacrimation, meiosis, and hypersalivation as well. So we use subcut atropine because atropine has is a very potent anticholinergic medication, and other drugs that will be used for chemotherapy-induced diarrhea, like octreotide and loperamide, are not potent enough for cholinergic syndrome, but are quite effective at late onset diarrhea. So as pharmacists, that medication history and symptom history taking can be really, really key to identifying the correct toxicity and the correct management of that toxicity. Bringing it back then to a person-centered approach. So what Dr. Gulpinar said earlier on about what matters to you, and this is really, really important to ask patients. Cancer care has evolved from a clinician decision model to a patient involvement model, and holistic care acknowledges the importance of the patient's overall perspective and actively involves them in decision making. So it's an expansion of the cancer-focused care into taking into account what matters most to patients. And this model here on the right was actually in a publication by the SPARC patient advocacy group in the International Society of Geriatric Oncology. And the comorbidity MDT here and the EBCC is evidence-based practice cancer care MDT. So they work in tandem with each other to manage the patient's comorbid conditions, but also their polypharmacy as well. And this is increasingly applicable in palliative care also. These are just two infographics then to kind of in relation to medication management. The one on the left is a figure that I put together for my own research, and it shows here that the prognosis-based, patient-focused pharmacist interventions are key. And in the palliative setting, we're identifying medications that can be rationalized or deprescribed, as was described earlier, or ensuring that cancer symptom control is prioritized, takes precedence over some of the other factors that we may take into account, because that might be far more important to the patient than actively treating their tumor. And also too, if we look at pragmatic clinical practice, evidence-based medicine is not just the best external evidence. So what do the trials say, the drug SPCs, but what is your clinical experience? And also too, it has to encompass patient values and preferences. That is a core fundamental aspect of good quality palliative pharmacotherapy. Just to highlight some very quick points from ISOP before we finish. The ISOP annual symposium abstract submission is open. The Understanding Targeted Therapies and Immunotherapies for Cancer course is now received the FIP seal, so it's great to collaborate with FIP on that. And ISOP membership is free, so join, sign up and collaborate with us. Thank you very much.
Thank you, Darren, and thank you for the pace. We have almost run out of time. It was very kind of you to go so fast. We have come to the Q&A, but we don't have too many questions. So how do I know if a patient is suitable for palliative care? I would say that would be the amount of pain they are experiencing. Can anyone offer another answer to that one?
Yeah, I don't mind if they have a symptom.
Very quickly, because we have to move on.
If they have a symptom. Palliative care is
If
about
they have a
symptom control and quality of life.
Yes.
So if they have a symptom.
Yes. Thank you so much. We'll just move on now for a quick wrap up. We had Elizabeth tell us about the WHO access, and that pain is physical, mental, emotional, and spiritual. We also had Eileen tell us so much about the same, but in expansion of our roles and talking about education. And Gizem was telling us a lot about how to build trust and suggested phrases that we could use. Also talking about education and training. So the thread that I felt was very common amongst the first three presentations today ended up with a conclusion about education and training, the importance of education and training. Of course, we can't go into everything in complete detail, and Darren kindly gave us an overview, a very quick overview, and I think I'll speak on your behalf, Darren. If anyone has questions, to send you an email. I think it would be possibly easier now with only a few minutes to go. I'll move on to talk about the fact that the recording of this episode will be made available on www.fip.org. Please provide your feedback on webinars at fip.org so FIP may continue to improve their digital event offerings. Visit events.fip.org for all future events. I'd like to also let you know that for more information and to register for the next webinar in the series, The Role of Pharmacists in the Care of Older Persons, please visit events.fip.org. Upcoming webinar include on the 29th of October, Pharmacy Practice in Long-Term and Aged Care. Before we end the session, let me tell you quickly that next year's FIP Congress will be hosted in Montreal, Canada, under the theme One Health, One Pharmacy, Building or Bridging Science, Practice and Education. The Congress will be supported by the Canadian Pharmacists Association, and our three themes are, as you can see on the screen here, integrated health, innovating with purpose, and collaborating for equity. Very important themes. So we finally come to our last slide to thank you all for attending and hope to see you again soon. Thank you all. Have a good afternoon, evening, night, morning.